Hello, everyone. Welcome to the third PsychSIGN Zoom panel Q&A of the season. This panel is a bit different than our previous two because rather than being concerned broadly with psychiatric residency applications, it more specifically concerns combined psychiatric residency programs and applications. In case you're not aware, these programs combine psychiatry training with training in family medicine, in neurology and internal medicine, or in child adolescent psychiatry and pediatrics. This last one is known as the triple board. Tonight, we are very lucky to have one faculty member and two residents who together are exceptionally qualified to speak about most of these programs. I think internal medicine is our blind spot today. But before I introduce ourselves and our guests, I just want to talk a little bit about the format. I'll structure the first 45 minutes or so of the night with a pre-prepared list of questions that we think are broadly helpful. While our guests are responding to one of those questions, feel free to post follow-up questions to the chat, and we'll try to take a few orally before moving on. I also invite the panelists to respond in the chat if they like to, in case we get an overflow of questions. I'll save the last 50 minutes or so just for audience questions. So I'm Sean, the PsychSIGN moderator, and will be helped tonight by Nishant Patel, our mentorship chair. You may send questions directly to him to stay anonymous. Nishant, maybe you can post in the chat. I also want to acknowledge Marissa Gilbert and all of our special interest chairs and regional chairs for helping to bring this event to you. So without further ado, I'll introduce our guests. Dr. Deborah Katz is clinical professor of psychiatry at the University of Kentucky College of Medicine and faculty associate of its Center on Trauma in Children. She formerly served as program director for the triple board in the combined child adolescent psychiatry and psychiatry residency program for 12 years. She completed residencies in pediatrics, child neurology, and psychiatry and child adolescent psychiatry. Dr. Raja Jawadkiani is a PGY5 resident and chief resident of the triple board program at Tulane School of Medicine. Dr. Rohit Abraham is a PGY2 resident in the combined family medicine psychiatry residency program at Boston University Medical Center. He is co-chair of the AMP Med Resident Mentorship Program and former MedEd counselor to the AMA. So with that, I'll start us out with a question for everyone. So please tell us a little bit about why you personally decided to pursue combined psychiatric training.
I guess maybe I'll start. Different people pursue combined training for a variety of different reasons. I think for me, it was important to kind of like figure out what I wanted to do with my life. I saw myself working with specific patient populations that were particularly vulnerable to what is traditionally considered non-psychiatric or medical problems. I kind of say that cautiously because psychiatric problems are medical problems. So, so my interest is in LGBTQ health. My interest is in eating disorders. I'm interested in chronic disease and associated mental health illnesses. For all of those things, I saw myself probably working in an outpatient setting or an inpatient setting as a consult liaison person, or I saw myself working in a partial program or something like that. I realized pretty early on that I needed a really strong background in pediatric medicine for me to be able to truly take care of my patients really well. I really needed a strong background in understanding, the mental health aspect of things. So, psychiatry was really important in child psychiatry too. So for me, triple board seemed like a natural path to be able to get me to where I needed to be and prepare me in the best way possible for the kind of patients that I needed to treat. So that probably was the most important reason why I picked a combined program personally.
So I'm happy to go next. I'm Deborah Katz. I'm in Lexington, Kentucky. really excited to be part of this tonight. I did not intend to do a combined training from the outset. I sort of fell into it. I went to medical school with the intention of being a child psychiatrist, and I think felt some of the pressure and stigma about psychiatry as I neared the end of medical school, and I wanted to do a residency in pediatrics to give me more grounding. So I trained in pediatrics and then became kind of enamored with pediatric neurology and thought that I could do what I wanted to do as a pediatric neurologist, what I could do as a child psychiatrist as a pediatric neurologist. So I finished that training and worked for a year on faculty where I'd gone to medical school, and realized that I'd really missed the boat, that I wanted to do therapy, that I love psychiatry, and I love the kinds of disorders that psychiatrists treated. I saw so much psychiatry as a pediatric neurologist, so I went back and I did psych and then child psych. And I have to say that at the end of all of this training, I really felt like I could do a comprehensive evaluation of a child from multiple perspectives. Having done pediatrics, and I'm sure those of you who are, looking at combined training have thought about the impact of seeing a lot of well children, to be able to know what normal kids look like, so that when something is different, you really know it. Unfortunately, in child psychiatry, you don't get that breadth of experience with normal kids. So I've been able to kind of combine my interests in different ways in different parts of my career, and I can talk about that at some point if you want. But I think what I did the long way around, I'm really happy there's a triple board program, has made it much more feasible to do that. So I'll stop there.
Great, that was awesome. So for me personally, my area of intersection that I'm interested in between family medicine and psychiatry is addiction medicine and addiction psychiatry. And so with these different perspectives, I think I'm really going to be able to take care of people that are facing addiction problems, facing primary care problems, and as well as psychiatric comorbidities, all in the same visit, and potentially even do therapy as well, depending on the payment model that I'm working under in the future. There's a lot to talk about with that as well, in terms of like how you can really freely practice. But I think really being able to like condense 4 different appointments down into one and really like do the most for the patients that require the highest level of care is really important and interesting to me. And so I sort of see my base population being patients with SMI, complex care management patients that are high utilizers in the emergency department and in the inpatient services. And I'm hoping to spend maybe like half of my days, like half of the weekdays in clinic taking care of those patients, but also working a couple half days in the psych ED, working a couple half days either on the inpatient medicine floor as a hospitalist or as a CL psychiatrist, and kind of like splitting my career that way into like multiple different part-time jobs, which is I think usually how people kind of stitch together the combined career. But we'll definitely talk more about it soon.
All right, thank you, everyone. It seems like you all addressed to some extent in your answers to the previous question, but I thought this should be addressed directly as well, just in case. It's a common criticism of combined training programs that a physician ends up practicing in a single specialty, even if they train in multiple specialties. How do you respond to this criticism and to applicants who are concerned that they might not have the opportunities they'd like to combine their specialties?
As someone who is graduating this year and is, like actively looking for employment opportunities and looking at things, I think I might be able to give you a relatively updated answer. Realistically speaking, when you look at opportunities and when you look at what is out there in the job market, particularly after you finish your training, what you realize is that a lot of it is dependent upon what the need of the population is, right? particularly, well, I'll speak for myself, like for someone who's gone through a triple board training program, and historically speaking, a part of our recruitment effort at Tulane has been to look at, historically, what have residents ended up doing after they graduated. A large chunk of triple board people in particular end up being pretty heavily involved in child psychiatry more than anything else. The reason for that is predominantly because there is a huge unmet need for child psychiatry in the community. Realistically speaking, if we continue to train people the way that we are and continue to fill all fellowship spots the way that we are, we will probably be able to meet the needs of the population in another generation. I'm talking 35 to 40 years. And realistically, and last year, if you look at the child psychiatry match, we matched about 50% of the spots nationwide. So we're probably not going to be able to meet the needs of the population. And so when you look at that particular dynamic, what you see is that institutions or private organizations that are looking to hire, they're much more interested in the subspecialty piece of it, the child psychiatric piece of it, which is why a large chunk of people are drawn into that realm. That said, I've picked a position for myself where I get to practice a little bit of pediatric medicine, a little bit of consult liaison. I do inpatient consult a little bit. I do an outpatient model of consulting as well. So you can kind of tweak your job, your future opportunities based off of what you want. One of our residents last year who graduated from the triple board program did a fellowship after doing the triple board program. He did a fourth board in palliative care, and right now that's kind of what he's working with because that's his interest. The other resident who graduated with him is working in fetal-maternal mental health and fetal-maternal medicine essentially, and started a program for moms and babies. So realistically speaking, you see a lot of people getting very creative with combined programs because we are in a unique position to be able to come up with new ways or new models of providing care for the population. Yeah, there is a chance that that you will be tempted to do one particular specialty, particularly from a billing perspective, depending on where you are. But you can always get creative, and you can always kind of advocate for yourself.
So I think similar to what was just said, I have done a lot of different things over the course of my career, from working in a pediatric neurology clinic as a neurologist and a psychiatrist, working with kids with chronic illnesses, working with dying children. But right now I'm mostly practicing straight psychiatry. And I have to say that everything that I've done, it's not so much am I working in general pediatrics, but that breadth of experience really informs what I'm able to do in an outpatient practice. And I think that that's invaluable, to be attuned to medical issues in a kid with diabetes, or a parent who has a chronic illness that might impact on the child. This is all part of the training, I think, that you get when you do triple board in particular. So I think there are a wealth of opportunities. Triple board was originally created as a path into child psychiatry for people who really felt like they could not give up pediatrics. And I think that that's one of the aspects of the people that choose this combined training, is that it just feels impossible to decide, and doing Peds is so essential that it seems impossible to give that up. That being said, there are certain issues that combined training brings up where you have less time in each specialty. You have to be able to transition quickly. You never really feel like you're fully part of one cohort of residents. You're kind of flipping back and forth. So I think if that excites you rather than terrifies you, then doing combined training is a good choice. But I guess I just wanted to emphasize that it may not be that you definitely practice all three specialties, but I think there's something about the vantage point that you come from that is created by doing the combined training, that no matter what you do, whether it's straight Peds or straight child psych, that is really unique and special about the training.
Okay, yeah. I totally agree with all that was said before me. And then I'll add like, this sort of like depends on who you're asking, right? This question kind of like gets at like the quintessential, like what do you do with med peds? Like you either have a person that is a pediatric age range or is an adult age range. And like, if you have an adolescent, you could kind of do that with either one without the other to some degree. And I get how there's an argument for med peds where like, if you were to focus on some specific condition and be like an ultra specialist in that, you could kind of follow it from childhood to adulthood. And like, there's like a good argument to be had for that as med peds. But I think especially with IM Psych and FM Psych, which I can speak to, like, I think more since that hasn't been spoken to as much, you can quite literally do both of these specialties in the same person at the same time for almost all of your visits. I mean, like half of primary care visits tend to be composed of mental health components. Many mental health visits have physical health components as well. And being able to address them both in a single person matters a lot. So it really depends on who you ask. If you look at the Association for Medicine and Psychiatry, that is the combined association for IM Psych, FM Psych, and the triple boards, as well as neuropsych. And so with all of those, they do a similar like alumni tracking program where they like try to see who does combined work after combined training. And they boast like I think it was like more than 70% or something like that end up doing like both specialties that they train in or multiple specialties that they train in. So I think it's important to just like kind of take it with a grain of salt in terms of like who you're asking and like what you're like looking to do with it. There's a lot of selection bias into like, hopefully they're picking people that are not just kind of like, I like everything and I can't decide, but they have a specific vision for how they're going to use it and a specific motivation for why they're going to use it. I think imagining from a program director's point of view, or like even a colleague's point of view, one of the worst fears is that like you know, match someone into your combined program and that they realize over their time that like psychiatry is less work for more money and decide to like just do psychiatry and like drop out of the other specialty. That is like the worst outcome you can have as a residency program. And so we really try to filter against that by asking people interview questions to see like, do you understand the disadvantages of doing this? Do you understand the advantages of doing this? And like, why do you actually want to do this? And I think that's important. I think like, not doing both is a sign of poor mentorship and like a lack of support from the program that shows you what you can do and like what you probably should be doing. But yeah, that's me.
All right, thank you. Sort of remind the audience that you can send in questions. I'm going to pivot a little bit, actually based on what Dr. Abraham just said, to a question about the residency application process. So aside from interest in all of the component specialties, what do your programs seek in candidates that may be unique from normal psychiatry programs?
I think different programs have different things that they're looking for, right? And sometimes it varies from year to year too. Just because, for example, like we're a small cohort of 10 people, right? So what we would like, the reason why I say that is there's 2 triple board residents at Tulane every year, and it is a 5-year program. So there's a total of 10 of us at any given point in time. And so, you know, it kind of truly depends on the year and the kind of individual that we're looking for. The most important thing for such small programs would be a fit. And it would be really like be meaningful for us to kind of like get to know as residents who the applicants are to see if they kind of gel well with the other 8 people who are going to be around. So I think compared to other programs, like, you know, like I sit in on the recruitment meetings for Peds, Psych, and Child Adolescent Fellowship and Triple Board. You know, when it comes to Triple Board, the residents have a lot more to say, at least at Tulane, you know, in that. So I think number one, getting along or kind of like seeing if you feel comfortable with the other residents would be really, really important. As a group, Tulane specifically, I mean, the worst thing that you can tell us in your interview is I couldn't decide between Peds and Psych, and that's why I wanted to do that. So I go off of what Rohit actually just said, and you know, we really don't want to hear that. We would like to know, you know, why you're choosing this particular pathway to get to, you know, your your future goal or what your destination is. Again, with a caveat that we're very mindful of the fact that you might change your mind over the course of 5 years. So you don't necessarily have to be married to the idea of, hey, I want to work with X particular population. You can decide or change later on. But I think that having a direction, having a vision, having a good, what we call triple board story, or having a good combined story, essentially, would be really important. So yeah.
I guess I would agree with all of that was said. I think the key question from coming at it from the program director side is really looking at what someone's motivation is and how well they've thought through this decision. There are many people that just sort of throw in applications to a variety of programs and sort of see what they feel as they go through the interview process, rather than to think through, I really want to do triple board, but I also know that there are, a discrete number of programs in the country and I might not match in triple board. So it's very commonplace to back up in either Peds or Psych or both. So I don't think that should be something to feel ashamed about to say. And then I think, the fit with both the Peds group as well as the Psych group, and interviewing with both groups, and those groups can sometimes be a little bit different. And from the interviewee's perspective, to see what you think of what the people are like in the program and what people end up doing. I think there was a question in the chat about, does it matter to have experiences in both Peds and Psych? I think having done clerkships in both is required of everybody. And I think program directors understand that there's very limited elective time, but I think the most important thing is to really think through what has happened during those clerkship experiences, and hopefully to have done something in your 4th year to, in either field, but more importantly, to kind of think through the process carefully about why you're applying in a combined field.
Yeah, totally. I would add on, I think, just to talk about other things that weren't covered. I think regardless of the type of combined field you're going into, there's a unique focus beyond categorical psychiatry about really zeroing in on social justice and underserved populations. I think the fact that you get so much training to give such a higher level of care to a lot of people is best utilized for patients who are high utilizers, who are complex care management, and who are typically facing many different social determinants of health at the same time. And so if you're interested in social justice, if you're interested in underserved medicine, I think combined training that's one reason to be interested in combined training over others. And then beyond that, I think it's important to portray what your honest interest is in leadership positions beyond just clinical care. I think we know that there aren't that many combined trained people in the world, and even if all of us were doing 100% clinical care all the time, we still wouldn't be able to achieve a population impact to the level that is necessary for the people that we serve. And so I think other people have mentioned, doing work integrated behavioral health, where you can be a consultant to an entire primary care clinic, or to an entire OB clinic, to an entire Peds clinic at the same time, and spend a half a day going through charts and just giving recommendations as an outpatient consultant to every other primary care provider, really enables the primary care providers to learn from you, but also for you to provide psychiatric care at a population level that is something that you just can't do as an individual. So things like that, if you have a vision for non-clinical public health leadership or non-clinical public policy leadership, I think all of those kinds of things are interesting and are worth talking about in an interview.
Okay, there were a few questions in the chat. I think the first 2 were answered pretty well in the chat. There's a third one. What is the difference in practice between receiving a fellowship in consultation, liaison, psych, psychosomatic medicine, and someone who is dual boarded in internal medicine / family medicine and psychiatry? Is someone who receives a fellowship in consultation, liaison, psych able to address medical needs of psychiatric patients, or is it more for addressing psychiatric needs of medical patients?
My understanding, based off of just the name in itself, is that your core aim as a consult liaison physician is to be able to completely understand what's holistically happening with the patient, but provide guidance and recommendations to the primary team on the mental health aspect of things. And obviously, with a background in combined training, you are especially equipped to be able to kind of like know about medications, interactions, medical illnesses and conditions a lot more organically, a lot more naturally. And the process of consultation liaison becomes a lot easier, a lot smoother. Yeah, that's kind of my take on it. Not that people who don't have a training in consultation liaison or a training in combined programs can't do CL work. They can, and they do it really well. I just feel like it's second nature to us, because that's kind of what we've done and what we've trained for.
I would also add that I think when you come from a combined program and you're dealing with colleagues, they see you as an internist or a family practice person, not just the psychiatrist who's on the consult service. So there is a difference in some of your relationship experiences with colleagues. And then from the Peds side, one of the questions that sometimes comes up is why not do a fellowship in developmental and behavioral pediatrics after a Peds residency versus triple board? And there is a real difference in becoming a psychiatrist than becoming a developmental pediatrician. Developmental pediatricians tend to work mostly with kids with developmental disorders, autism, learning disorders. And psychiatrists, child psychiatrists, see the whole spectrum of psychiatric illness, including those that I just mentioned, and are able to provide psychotherapy, which is a huge aspect of practice, to have that kind of training, to be coming from a psychotherapeutic stance and to know what it is to work psychotherapeutically over time with patients and with families. So I think there are big differences in that area as well. I just wanted to mention that.
I would totally echo all that was said before me. I would add that, like, in terms of hiring, if you know that like consultation liaison work is something that you want to do, like I'm interested in doing CL work like a couple, maybe like 1 or 2 half days a week, but not having that be like my primary career focus. So knowing that, I think having combined training gives you a lot of like really good background. But I think in terms of the reps of like really classic consult questions, like capacity questions and like other things that like you can really only get good at by just doing many different situations and like just knowing the nuances, I think there is some value to doing a CL fellowship. And practically speaking, if you're trying to get hired at an academic medical center, unless you're from that place as your home institution or you're just like well known in the area and people can speak to you, it may be challenging to get hired as a CL psych consultant without having done a CL fellowship. If you're in a community hospital or a rural area, I think it would be a lot easier to just show up and say like, hey, I did combined training, hire me. And they probably would. But I think depending on like how like prestigious of a university you're trying to work at, that may or may not actually happen for you without doing an additional fellowship. But I agree that like it is like naturally what we do as combined folks is to be liaisons between the fields and to think from both perspectives. But to the original question asker's, I guess, perspective, a CL fellowship does train you more to take care of psychiatric needs of hospitalized patients. It does not train you to take care of medical needs of a psychiatric patient. That is not generally what it does.
I would like to add one thing to what Rohit just said. What he talked about is 100% correct. Only it does not apply to child or pediatric populations because, there's no child CL trained folks out there. And literally like people anywhere are, really, really starved of child psychiatry. So if you are a child psych trained person, it doesn't have to be a combined training. If you have a fellowship in child psychiatry, they will eat you up and, really, really are looking for you everywhere. So that's the only exception, I guess, to that. But otherwise, I completely agree with Rohit.
Actually, coming off of your response to that question, there's a question I received, or that Niche received in the chat, that I think is interesting. There are very few combined residency programs. If one is not accepted into a combined residency program, what are alternative avenues to being a dual boarded FM Psych, IM Psych, Ped Psych physician? Two residencies?
So at the end of the day, I mean, the world is your oyster. I mean, if, you know, you can kind of like the advantage to doing combined programs is that it cuts down the total amount of time that that you're spending. Like my training in pediatrics, general psychiatry, and child psychiatry would have been a 9-year training. I'm doing everything in 5. So that's the biggest advantage that I have. But realistically speaking, if I were to feel like I want to do each and every residency and go through that, nobody's stopping me from doing that. In fact, you know, programs will like welcome, you know, anyone with that kind of passion with open arms, because they would want someone who's, you know, that driven to be able to kind of like get to that particular their endpoint. So yeah, there is options. Like, you know, like I said, triple board for me was just a path to getting me to where I wanted to be. Alternatively, could I have done a residency in psychiatry and then done child psychiatry and then continue to see the patients that I aspire to see, that I like to see? I probably would have been maybe able to do that. Could I do a fellowship? Could I do a pediatrics residency and do the pediatrics portal kind of pathway? Which again is there's not a lot of them out there, but there are some that are out there. There is, you know, that pathway as well, where you do a 3-year residency, and after that you do a 3-year training in 1 year of psych and 2 years of child psych to kind of like be essentially, you know, a child psychiatrist at that point in time too. There are many different avenues to getting to your endpoint or your goal. You just have to decide, as you know, as an individual, what fits best for you and what's the best, you know, pathway in terms of time, in terms of duration. Remember, combined residencies are not without, you know, their drawbacks, right? Dr. Katz already mentioned a little bit about this, in the sense that, you know, my total general psychiatry experience is about 18 months, right? As opposed to 48 months of what a traditional gen psych resident kind of like goes through. So, so it's not without its costs, but for those of us who are applying into these programs, it kind of makes sense. And you got to decide if it makes sense for you.
Dr. Katz, I feel like you'd be best able to speak to this, having basically done this.
Well, I agree with everything that, you know, was said. I don't have a lot to add. I think that the PPP program for pediatricians is one avenue in. There are some restrictions on funding at some schools, so that if you would want to train consecutively like I did, there are federal funding limitations now that the department would have to pay the cost of your training and not have that subsidized. So there are some schools that just financially can't do that. You know, I think that if you really know that you want combined training, that you should apply for combined training, but to be aware of some of the limitations of it. And one thing that, you know, was mentioned is it's 18 months of adult psychiatry. You have to take your adult psychiatry boards just like everybody else does. And you might be practicing some adult psychiatry. So to really think if you're going to feel adequately trained after that amount of time, there is a lot of independent learning and catch up that you have to do if you, I think, do combined training in every field, whether it's, you know, you don't have as much peds, you don't have as much child psych, and you certainly don't have as much adult psych. So to just really be aware of that. And there are people, you know, that will, in their first year of pediatrics, decide they want to do triple board. And if there happens to be a spot open as a PGY2, that's a possibility. It's rare, but it does happen. There are triple board people that do leave training because they decide they either want to do peds or they want to do psychiatry. So, you know, it's not completely set in stone, but I think during your 4th year to really try to do as much work as you can, to talk to as many residents as you can, to make sure that you're choosing wisely. It's often very hard, and I don't envy you having this whole Zoom process where you can't actually go and meet people. So I'll stop.
Yeah, I think we're all kind of nervous about the Zoom recruitment season. It's very strange, but I don't have a ton of experience speaking to this, being in a combined program myself. But I would say that, like, from what I've heard from others, the sequential training route where you would do one or the other and then follow up with one or the other specialty is, I think thought by some to be like the true way of doing combined training. I mean, to some degree, like, you overcome some of the disadvantages of like getting less training in a particular area and like really can think truly like one or the other and like be independently trained to do both fully. So I think that is like one advantage to doing sequential training, although the time and the cost is a separate issue. I have heard also from other people that have pursued this that, like, if you have to choose one backup and you don't think you're going to match into combined training for whatever reason, doing internal medicine first or doing family medicine first or even doing pediatrics first is probably a better route, in that like you may be able to skip some or all of intern year of psychiatry, having done so much medicine. There's really like little sense in repeating all of the intern year medicine rotations if you're board certified in internal medicine. So as just one example, that could be a way to speed it up, even if it is sequential.
There's one question that came up in the chat. Someone is interested in primarily developing innovative integrated care payment models. They're asking, how do you show that you have an interest in a non-clinical area in your application without suggesting that you don't care about clinical work?
I don't think that you should worry about that at all. I think that there's a wide breadth of interests among combined training residents and interest in integrated care models, public policy, advocacy. These are all things that are very attractive to programs and bring diversity to the program. So I think that should be a point of pride rather than something that you should be worried about. Obviously, you're doing clinical training and you want to treat patients. I wouldn't underemphasize that, but I think it's totally fine and an asset to mention those interests.
I think the best place to showcase them would probably be, I mean, if there's no way that you can do it in your resume or your ERS application, and then in your personal statement, if you can talk about it as a passion of yours or however it may fit in with that. But I'm pretty sure that if you're passionate about it, it's definitely going to come up in the interviews at the very minimum. And like Dr. Katz said, every program would be more than happy to kind of like talk about it and think of it as a positive thing.
I also totally echo that. I think this is like no more than a positive thing. Although I will admit that as an applicant not too long ago, I was nervous about this. And I was nervous about this because I felt guilty that I had done an MPH between third and fourth year of medical school. And during that MPH, I had strongly considered not doing residency. And I think there were moments in that year where I was like, yeah, I could be happy not doing residency. And then later on in that year, I was like, wow, I really, really miss direct patient care. I don't think I could ever not do patient care. And that was like an important realization for me. And I talked about that on my interviews. And I think that's important to kind of showcase that, like, yes, like you do care about patient care, especially like from your CV or from other things that you've done. It comes across as if like maybe there's like a lot of things that you want to do that are non-clinical. Like if you're concerned that people will get the impression that like, does this person even want to do medicine? Maybe just like affirm that you do. But I think like that's not a hard thing to do. I mean, you're applying for residency, and applying for a 5-year residency kind of implies that you're committed to doing clinical work. Hopefully.
So before moving on to more audience questions, one thing I just wanted to bring up, just in case you have any information, is how the Zoom interview season will work at your programs. You're already very small programs. There are people who are applying way more broadly this year. I was wondering if this is affecting your processes in any way, how this might be relevant to applicants.
So most categorical programs are going to be, at least I can speak for Tulane, are going to be interviewing more applicants than they traditionally have, and that's just kind of the way that that they're deciding to do it. And we are appreciative of the fact that, you know, most applicants are going to be applying way more broadly than they have historically, and just also going to be able to attend way more interviews because it is virtual and you don't physically have to travel as much. So the costs that are associated with it are going to go down, and a lot on the time that is associated with, you know, all these interviews is going to be cut down, so that people are going to probably be interviewing at more places. So yeah, most categorical programs are doing that. As a group, the triple board program over here at Tulane is probably not going to be interviewing any more people than we normally have. We originally thought that we would, but when we did the numbers and, you know, added things up, it kind of equaled out for the most part. So it's going to be pretty similar to what we've done in the past. Our interview days are going to probably look very similar to what they have historically, in the sense that we're going to kind of emphasize on kind of like lumping the interviews together and making it more concise. Probably going to be a lot less number of interviews than we have had historically per applicant, for example. You know, back in the day, I feel, you know, like it was a while ago when I joined residencies 5 years ago. You know, I'm pretty sure that when I interviewed at Tulane, I had like a good 8 interviews with different people, you know, at Tulane. But I think now we're going to cut it down significantly to like 4 or 5 people at max. The one thing that we're going to focus on as a triple board program over here at Tulane is trying to see if we can maximize the interaction that applicants have with residents, because historically speaking, that has been something that has been very meaningful in our rank meetings, in our application or in our applicant, you know, rank lists and things like that, and recruitment efforts too, because we want to be able to kind of like get to know the applicants well, and want to give them the opportunity to kind of like see who we are and how happy we are with the program or whatever. As applicants, I would really advise that you kind of invest into that as well. You know, if you see a program where the residents are cranky and unhappy and, you know, just miserable, that's going to be you in a year, you know? So you want to kind of be cautious about that, as opposed to if you see, you know, a program that you feel like, oh, well, these guys are kind of like, you know, my vibe, or, you know, these guys are kind of like, you know, people that I see myself hanging out with in a social way, or people that I kind of, you know, feel comfortable around, then that's probably the program that you're going to fit in well better with. But yeah, so those are some of the things that we're doing at Tulane. I'd be more than happy to be more specific. You know, if you have any questions, feel free to email me or anything about that, and I can kind of like go from there.
I can't really speak to Zoom interviewing because I'm no longer a program director, but when I was program director, we would usually interview somewhere between 20 and 30 people for 2 spots. And I would strongly encourage you to reach out to residents after the interview day to have private conversations and to follow up on things that you weren't able to cover in the interview day, because everybody is sort of putting their best foot forward during the interview day. And not only does it indicate interest in the program for you to reach out and make that connection, but you're able to hear sort of unofficial perspectives on the program that you might not be hearing during the interview day. So I think it's just due diligence, if you're truly interested in a program, to try to meet some people and to hear more informally than you would get during the interview day.
Yeah, so in terms of the numbers, I think there are approximately 15-ish IM Psych programs and about 6 FM Psych programs. There are a couple here and there that have talked about like opening up, but I don't think that's happening this year in particular, probably mostly because of COVID. But in the coming years, we are expecting there to be like 1 or 2 more FM Psych programs in the country. I know, at least on the FM Psych side, depending on the program, they interview usually between 16 to 30 people a year. And our program is thinking about closer to 30 a year this year, partly because of COVID and partly because we're just a newer program. We're going into like our 4th year of our residency. So though like both of our categorical programs have existed for a long time, the combined program is new at our institution. So from that point of view, we want to make sure we fill our spots. And so we're interviewing some more people. Other than that, I think like the virtual interviews are going to be a mystery to us as much as you guys. We're trying to do more Instagram recruiting with like videos that are semi-professionally done, trying to showcase more like, you know, like stories that are like takeovers of what a typical rotation is like, so that you can kind of get an element of a hospital tour as well as like just kind of like a shadowing experience to some very limited amount in various different clinical contexts, so that you can get a sense of like, oh, that's what that clinic looks like. Oh, that's what I would be doing if I was on the consult service. Oh, that's what I would be doing if I was in clinic doing this particular subspecialty. And that's kind of a nice way to show you a little bit more without you physically being here, but it's not perfect. I think from our perspective, we're doing afternoon interviews. They won't be the whole day. And our particular institution does like a combined interview that is separate from the categorical ones. You can additionally interview for the categorical programs, but in the combined program, you typically would interview with all of our program directors, of which there are, I think, like 3, not including the categorical ones. And then you typically interview with 1 or 2 residents as well, just to kind of get a sense of like what we're like. And then that is generally it. We usually don't have categorical FM or categorical psych residents or faculty interview unless we like need to fill interview spots in case something's going wrong. But just to make someone feel better out there, when I was applying my year, I applied to the FM program categorically as well as the combined program at my institution. And I was denied from the FM program categorically, and I'm still here. So if that happens to you, that doesn't necessarily mean anything. That's all.
Yeah, I think Tulane just does that very similarly. If someone is applying into, excuse me, someone's applying into double board and Peds, you'll get a hybrid kind of model of an interview. We're not going to kind of interview you on 2 separate days. It's going to have to kind of like be tailored to it. So yeah, you just have the regular triple board interviews and a bunch of extra ones, I guess, perhaps. But yeah, or sometimes not even necessary, depending on what the number of interviewers for Peds was. Same for Psych.
So there's a question, I guess, about the relative importance of specialties within combined programs. Do you think it's beneficial for most child psychiatrists to have more background in pediatrics as opposed to adult psychiatry?
God, it's kind of like, you know, I think it depends on the context in which they're working. It's kind of like, you know, me saying, you know, touch your eyebrow, and so you can either do it like this or you can do it like this, and you know, they're both kind of right. And I think if you're going to work with a population where you need a strong background in pediatric medicine, like if you're working with kids who have oncological issues, if you're working with kids with chronic illnesses, if you're working with kids who have, you know, eating disorders, things like that, then I would say background in, or even LGBTQ patients, things like that, where a lot of like medical problems are integrated into the mental health, you know, aspect of things. I think it would probably be better to have a background in pediatric medicine. Otherwise, if you're seeing patients and are doing a lot more psychotherapy, if you're seeing patients and kind of like doing a lot more, you know, family-oriented work, you know, or a whole myriad of other things, you know, particularly in an outpatient setting, and seeing child psychiatry in an outpatient setting, I would probably say that, you know, you can kind of like go into Gen Psych residency and fast track, and you know, so that would be fine. It's kind of like the answer. There's no one one right way. The beauty of psychiatry, by the way, guys, is like psychiatry is so gray that it's just absolutely fantastic. There's often no one singular right answer. There's a bunch of right ways of doing it. And it's the art form of psychiatry is kind of figuring out which particular route is the best route in that particular patient or that particular scenario. And in this case, what route fits best according to what you want to do. I'm sorry, that was a non-committing answer, but that's the best that I can give you. That's as gray as a response as you'll get from me.
And I'll also add that as I look at my career, I've done very different things over the course of my career. What I'm doing now is I did psychoanalytic training after all of this, and I'm practicing psychoanalysis and psychodynamic psychotherapy with adults and children. And I'm working as a consultant to a child trauma center. So I'm not really doing anything that's straight pediatrics or even general medicine right now, but I think it's not so much what you think you might do right at the end of your training, but the arc of a career is long and there are various things that you do at different phases of your career. I really enjoy treating adult patients at this phase of my career. Being on the floor sometimes is a little much for me. So, I think when you do general psychiatry, you have to do 4 months of, well, I don't know if it's 4 or 6 at this point, but of either internal medicine, family practice, or pediatrics. And some programs let you choose what you want to do. So if you do general psych, you can do all peds, and that will give you better grounding in peds. It's not like doing triple board, but it is something that's better than, 1 month or whatever. So to think about that as a question, maybe if you're looking at backup in psych, about whether you might be allowed to do that particular specialty that you're interested in, whether it's internal medicine or peds or family practice.
I don't know that this question was applicable for me, so I'll just pass.
Okay, I'll ask one more. I see the first one has been covered in the chat. So the last one is, after graduating from a combined program, what is the greater culture of working in a combined specialty like? Since there are fewer combined psychiatrists and general psychiatrists, are there specific conferences, for instance, or do you find yourselves networking more in separate specialties?
So I guess the cohort is so small. Like there's literally like from a triple board perspective, there's like between 18 to 21 of us every year. So do I know the other PGY5s in other programs? Yeah, because it's just the way that it kind of works out. We work together off and on, and we kind of like attend the same conferences. Sometimes we liaise with each other when it comes to setting up things. So within us, yes, you do have ACAP, which is the American Academy of Child Psychiatry conference, which is, by the way, happening this week and next week, and so it's pretty heavily attended by a lot of combined residents. And when I say combined, I'm specifically talking about like folks that are in triple board in particular, and they have like specific subcommittees for triple board and specific events for triple board as well. So you do tend to kind of like have a great opportunity in networking with people that are combined trained. I think because the number of child psychiatrists in this country is so small that like anywhere you go, you kind of like run into the same names and run into the same people. Like I was interviewing at a bunch of different places for my job employment, right? And people were talking about we have infant mental health here, and we got to work with Mary Margaret Gleason and and Charlie Zena, and I'm like, yeah, I do clinic with those guys, and so it's kind of like the same names sometimes will pop up in different contexts and whatnot. So it ends up being a lot of people know a lot of people, and from a sociability standpoint, there's certain individuals, certain physicians who are way more involved in academic work, etc. My program director, Mio, is notorious for, for interacting with other specialties, with other triple board programs, other combined programs, etc. And I don't see myself being able to do half the kind of like networking that he does. So I think it kind of depends on what you want. As far as the culture is concerned, I think that there is a tendency for it's open. I feel like it's you decide what fits best for you. There's naturally avenues for you to be working with triple board people, working with combined people, working with child people specifically for triple board. But if you want to spread out and do other things as well, it's not unwelcome. It's not unheard of. It's not something that is even uncommon.
I would add too that there are a number of subspecialty organizations like infant mental health or college mental health, eating disorders, substance abuse in adolescence. I mean, there are lots of different organizations that psychodynamic psychotherapy that you can join if you have a particular interest or sort of fit with what the work is that you're doing.
Awesome. Yeah, I'll take this opportunity to make a plug. AMP actually starts tomorrow and is this weekend. One really cool thing that they have going on, and of course it's virtual this year as everything is, but they have a residency fair between IM Psych, FM Psych, Neuropsych, and Peds Psych. And that's a nice way to just kind of like meet a bunch of the programs at once and get a feeler of like, oh, these people do this. This is what that curriculum looks like directly in comparison to this curriculum, because they'll have posters of what the 5 years look like mapped out in rotation order and stuff. So that can be really helpful to compare for yourself. They also have like speed dating events between medical students and residents. So you can like quickly get to know a bunch of like people in a particular combined specialty and be like, wow, those people are really cool. Or like, those people are really kooky. I could never do that. Other events they do, like other people mentioned, there's like medical student committees so that you guys can get involved in like leadership positions around certain combined topics that could be more like med psych oriented. Yeah, there's really like a large gamut of things. And if you're interested in having like a longitudinal mentor for IM Psych or FM Psych or the triple boards or Neuropsych, you can also sign up for a mentorship program that like I partially run on the FM side to get paired with somebody, hopefully from your geographic region or from the program in the region that you're looking to train in, that can give you like sort of like longitudinal guidance over like, maybe explore these things preclinically, like maybe think about these things to really decide if this is for you. Maybe this is really not for you based on the interests you have. And then kind of like working through your personal statement and other elements of your application as you go through the process. I also use my AMP mentor to kind of like inform my rank list. Like I really heavily utilize them for a lot of things. And because they were so in the know of my application, they were willing to like recuse themselves from any rank list discussions around my candidacy. And so that was really nice for me to feel like I could be open and honest with them and not have it impact my ability to like match wherever. So those are some of the reasons to join AMP as a medical student.
And I'll just add that if anybody here has an interest in psychodynamic psychotherapy or psychoanalysis, or if I could be helpful on an individual basis, to please feel free to reach out to me. I'll put my email in the chat. I'm not a program director. I have nothing to do with the recruitment ranking process, and I'd be happy to be available.
Likewise, same for me. I mean, like, I am involved in recruitment. I am the recruitment chair for my program, but I'd be more than happy to answer any questions that you guys have about our program. And the specifics of like, what we do on Peds, what we do on Psych, what we do on Child Psych, and all that. So please feel free to reach out to myself as well, and or anyone from our team at Tulane. My program director is really good at answering emails, and my co-chief is as well. So yeah, that's about it.
Okay, I just want to thank everyone, all of our guests. We really heard some excellent information today. It was a great panel. Just in case you missed the emails in the chat, feel free to contact any of us at PsychSIGN and we'll forward you the information. Yes, and that's it. Thank you for attending as well. We hope to see you at a future event. Good night, everyone.
Good night.
I think, thank you for having us.
Thanks for having us.